You will be able to create a profile for yourself and access your CPD certificates. The event for tonight's webinar qualifies for 1 clinical CEU. We are streaming live on YouTube as well, just in case you have difficulty to access the Zoom platform. A reminder to complete the webinar, the evaluation after the webinar, and throughout the webinar, there will be polls that you should answer. Just a list of upcoming events that you need to make note of is on the 4th of March, there will be a SADA Dental Assistant Recognition Week, the physiological impact of COVID-19 on dental assistants and laughter, the free of charge stress buster brought to you by Mrs. Ntubi Tabatso and Ms. Elise Jacobs, both dental assistants. And on the 9th, 16th, 23rd, and 30th of March, there will be a Endodontic Society bringing 4 international speakers to the podium, celebrating World Oral Health Day during March. And on the last and 25th of March, there will be Dr. Antoinette from the South African Depression and Anxiety Group, who will speak on resilience and depression. I will now introduce our speaker, Dr. Heinrich Dippenaar, who has a special interest in orthodontics and is logging on all the way from Plettenberg Bay. Over to you, Dr. Heinrich.
Thank you very much, Kurt. I think I can start sharing the screen. All right. Can you see the screen, Kurt? Everything fine?
Yes, we can. That's
all right.
Yeah.
Good evening, colleagues, friends, and for the SADA webinar. Thank you very much for the kind invitation. And yes, thank you that I can spend the evening with you, and I hope that you can take benefit from this webinar. I do want to say that this webinar is not sponsored by any company. I'm not paid by any company, and this is purely out of really a love for endodontics. Although I do general dentistry, my passion lies with endodontics, and it's probably out of respect for my colleagues from the Free State who asked me, please, can I do a webinar for the branch? And Marlies from SADA, who throughout the years of lecturing for them has become a good friend and maybe a persuasiveness. So thank you for having me tonight. So I'm going to dive right into it. We're going to look at apical control in endodontics. You know, there's myself gave a few. There was lots of webinars on new files, how you prep, what you do, irrigate, rubber dam. But and I tried something new. They wanted a specific topic for endodontics. So how do we get to the APC? No matter what file system you use, no matter what method you believe in, and maybe a few views and things to consider. If I show you this extra, and it's maybe the talks of tonight, case done by myself, one of those which you probably will put in the lower drawer. So I had to tell you the amount of time spent in trying to negotiate this tooth, the length, and I couldn't manage on the visual route at all. You know, we always like to show all these beautiful cases with star-like lateral canals, but is that all necessary? And maybe something to take from this, there's more than just the file and the 3 white lies on an x-ray that we all like to refer to. There's coronal seal that's important, irrigation, etc. What might be of choice is that this case is now almost 3.5 years old and it's still looking relatively fine. The periapical area at the distal root has disappeared and it looks stable in the front. So, and that we've seen a lot with cases that doesn't look as good and on the x-ray, but clinically, and I'm speaking specific about the canals that are filled, clinically they perform well. So is there more to it? So Tsepo, if you can run the first poll for me before we start. So where do you stop your endodontic treatment? And I'll leave it for a few seconds, and then we'll. I hope you can share the statistics with me, Tsepo. So do you believe that you should stay 1 millimeter short of length, 2 millimeters at the radiographic apex, or at the cement to dentin junction? What is your preferred belief. Tipu, are you live?
Doc, yes, the poll is running.
Okay, I have to. Okay, can you share the results with me, Tipu? All right, so 55% of people say 1 millimeter short, 62%, and 30% at the radiographic apex. And then there's a few 12% that say at the cemented dentinal junction. So where do we start? Is it now the 1, is it the 2, or is it the 3 more? Because endodontics, we believe in measurements, we believe in millimeters, and that's what we aspire to. If you go to Scandinavia, they will tell you 2 millimeters short. Most dental schools will say 1 millimeter short. If I show you this image and I show you this root canal treatment, how would you rate this? And Chipper, if you can share this, I'll just show it again. There's the X-ray, and I want you to share the second poll with me, please. If we look at the statistics, this is a failure. We know that the radiographic apex, and I'm speaking purely about the poll, we're 2, maybe 2.5 millimeters short. We don't know where's the CEJ. So how would you rate this? Very good canal, canal is short of length or under instrumented, and not very good obturated. Okay, Chipper, give it another 15 seconds or so, and then straightforward, you can share the results with me, please. All right, so under instrumented obturated, root canal is short of length, most of them, and some would say 13% it's a good endodontic procedure. Well, the info that you didn't have is, and how do we rate it? We purely look at 2 things. We look at length and we look at the white line, and then we make a decision, is it good or bad? Well, this root canal was done by myself not too long ago. There's my length determination. That's the obturation. But what you didn't have is the CBCT view, which shows you there's about a 3 millimeter gap between where the cemento dentin junction, and there's the radiograph to show you that it was actually very well obturated and sealed. Right at the spots. One thing I want to make you attend of is that there's no big periapical area, and the patient had a discolored tooth due to trauma when he was younger, and we did some internal bleaching for him. So conservatively prepped, no puffs, no periapical area. That's the things that I want to try and focus on tonight. Should we have puffs? Should we strip open the apices? Where do we stop? How do we prep it? Not what file system you use and how, or the type of sealer that you use, but all right. So if we look at a normal slide of a tooth, histologically, what do we have? We have the cemento-dentinal junction, or we can call it the apical constriction, and it might differ on an X-ray or in a real life in clinic. We have the radiographic apex. Remember, a lot of you say, well, we have to work at the radiographic apex because that's what we use. We use the radiograph, we measure it on the radiograph, we will deduct 1 millimeter, and then we are happy. Or we have the major foramen. Do we prep to there? Do we fill our sealer to the major apical foramen, or do we keep it short at the apical constriction? Well, this was a very interesting article of 22 pages where they looked at different things. I wish I could share more of it, but different aspects dating back to 1933, 1944. You can see old guys, old gurus, all loving endo, purely based on endo. Should we prep short? Should we be longer? Different anatomy at the apex, different histological slides. Quite a long but a very interesting article. Look at all the foramina, different slides, different concepts, and different guys' views of denting and what they believe should happen. Well, in 1968, the first World Endodontic Conference was held. That is 68 years ago. And the main crux that came out of this was that Louis Glossman said that we shouldn't do traumatic injury to the surrounding periapical soft tissue, and we should avoid that at all times. So it is normal to presume that our instrument should stop within the root canal, and that canal filling should seal the apical foramen, and that if the apical millimeter or so of the canal is filled with healthy tissue, that's what we want. We don't want our sealers to puff through. We want healthy tissue, and we want to stay just short at this terminus. 68 years ago. I was fortunate enough in 2013 to attend the 9th World Endodontic Conference in Tokyo, Japan, with guys that you all recognize from South Africa. And even then, it is debatable in lectures. 8 years ago, 68 years ago, to where should we prep? Should we do patency? Should we be 1 millimeter short? Should we be at a radiographic terminus? It's still debated up until this day. So how can we make it in today's world with all the technology that we still are debating? So where should we stop? Isn't there a better way of determining case by case? Because not a single case is the same, not a single tooth is the same, and you can't take the general rule for all. So in 1930, I know it's dating back a lot of time, but just to put the ground for where I'm heading with this, they looked at slices, and they found that when there was dentin, there was pulp tissue present, if they look at it histologically. If there was pulp tissue, there was no cementum. And if there was cementum, there was a periodontal ligament. And that's maybe an indication from where we should prep our canals to. In 1955, Cutler investigated microscopically the root apices under light microscopy, and he evaluated 268 teeth. And this is out. In younger patients, 18 to 25 years of age, there was a difference between the apical foramen and the radiographic apex in 68% of cases. The cemento-dentinal junction was unidentifiable, even at younger children. And we say we should prep to the CDJ, cemento-dentin junction, but it's undefinable, so we can't find it. We don't know exactly where it is, although that's maybe where we aspire to. But how do we get to that point? And it's uneven because we get cementum that lays down, we get growth, bone formation around the teeth, and then it changes throughout our life, where it ossifies more, where it becomes more dense, the enamel changes, the prisms changes. At patients 55 years and older, there was an 80% difference between the apical foramen and the radiographic apex, which is quite huge. And yet, we aspire to work maybe to the apical foramen, to the radiographic apex. But how do we do it if it changes in 80% of cases, where it's unidentifiable? So the CGDJ is a convergence of two histological tissues, the dentin and the cementa. And that's maybe where the pulp tissue stop and where we have healthy cementum and PDL forming, and that's where we want to prep our endodontic treatment towards. The apical constriction is the other method, because that's maybe where we can feel at the constriction. That's where the CDJ is. Again, I want to show you this case. A young colleague who's working under my guidance, and he shared with me this case, and he maybe done more good than what he was realizing. A nice case, you could see there's total distortion at the cemento-dentinal junction. The radiographic apex differs from where he stopped his case. And you could see another thing which I will highlight. Very apical area, maybe a puff of sealer through the canal, and very good healing. And this case was done by Dr. Daniel Rousseau. So excellent case done. What I've told you now, we want to be maybe at the cemento-dentin junction with a little bit of a puff when there's a periapical area. But how do we determine where that exact spot is? Because if you look at the radiographic terminus and the apex, and that's where you want to prep to, you might be prepping too long. You might strip perforate the case. You might cause iatrogenic bleeding and lots of post-op pain, because now there's lots of sealers that are going to run through, lots of pus, and that causes chronic inflammation. So the CDJ is where we want to prep to, but how do we get to that point? That's for me where it is predictable at the apical constriction, and it might not look so good on an X-ray, but that's clinically the only thing that is repeatable in every clinical situation on every tooth. Well said, but how do we get there? We can't, even if you believe that you should be 1 millimeter short, how do you get to that 1 millimeter? How do you know that's where you want to be? So the aim of this lecture is to maybe tell you that we want to try and focus to get to the CDJ, and we want some healthy, nice tooth, tissue underneath it where our immune response can be active. And with GP just being short of that, with maybe a millimeter of biological sealer in between our healthy tissue, that it can stimulate cementum forming. And that's the very clinically where we want to aspire to. So factors affecting long-term results in endodontic treatment, very interesting. They looked at a 10-year retrospective study of 356 patients, and they divided into teeth that had vital or non-vital without a periapical area, and they could determine a 96% success rate of endodontic treatment. When there was a periapical area present, the success rate dropped to 86%. When there's a periapical area and they retreated the case, they could only get 62% success rate. So good study done, 1990 by Sjogren. So this is what they found, that if they look at the case, more break it up, 69% when there's no periapical area, but only quite a big change when there was a periapical area present. And then they went further and look at the cases of where there was a periapical area present, and they found that if they prep the canals to 0.5% or 2.5 millimeters of the apex, they had a better success rate. When they over-prepped it with lots of sealer or maybe GP sticking through, it fall down to 76%. If they were very short of the canal, 3 millimeters or more, they had a worse outcome than when they over-prepped it. But very important to note that if there is a periapical area active, that they should be at length, otherwise the success rate decreases. So the success of our endodontic treatment is dependent on the instrumenting the canal to length and to a level of we could get root filling material right in contact with maybe our immune response. Another study, and I know I don't always like to look at studies, but we have to study and to lay the ground that it's not thumb sucking. Endodontic infection and some biological factors associated, where they looked at a 5-year to 4-year retrospective study of 200 endodontically treated teeth, and they looked at diseased periapical areas and the level of working. So again, when there was no periapical area present and they were 1.5 millimeters short, they had a higher success rate. When they had a periapical area present in the cases and they were with 0.5 millimeter of the radiographic apex, they had the best success. And they concluded that for every 1 millimeter that you are short of your working length, the odds is 14% of a higher failure rate for every millimeter stick back. So it's important to prep to length, to be able to obturate to length. And that's the only purpose of an endodontic file, is to create a funnel in which we can irrigate and obturate. But we need to do it predictably. It's easy to say 1 mil or 2 mil, or radiographic apex, but how do you do it clinically and how do you achieve that? Because looking at a histological slide like this, where they use seal apex, you could see that when they have a nice 0.5 to 1 millimeter short GP cone with a little bit of sealer, we have a healthy response of our immune response and cementum forming at the apical area. If there was lots of sealer and pus pushing through, and this was a a vital case, then there was an immune response and chronic apical reaction. And that's what we want to try and avoid as well. So I want to try and highlight a few things and how we can do it. So yes, me, myself, and a lot of guys were preaching about patency, where you take a file and minutely go through the apex of the tooth to loosen debris, to make sure the tissue is gone. And that's what we've been preaching, and myself included. So the medical term for patency is that it is not blocked and not obstructed. So you take a file, you push it through, and you pull it back, and that's the length. So again, it's not about millimeters or 2 millimeters. It's about getting past the constriction, creating patency. Very novel, and it's all great. But what if this is your case? Look at the CBCT of this lower premolar. And look at the apex that you can see right in the mental nerve. Is it still viable that we take a case like this, do patency after every file, pushing it through, and then we don't know how far do we exit because we only use two-dimensional imaging, and that you might be poking right on the mental nerve and cause paresthesia post-op. Or you irrigate and irrigation solutions go through and you're right into the mental nerve canal. So do we need to do patency on every case? There's a periapical area. I want to control it. There's my post-op image, and look at the nice bone healing, bone formation over the mental nerve. How do we do something like this predictably? And how do we avoid get sealer pushed through the canal? And is it still viable that we do patency on every canal 10 times throughout our procedure? Depending on the system you use, depending if you use, for instance, ProTaper Gold, we have a S1, S2, F2, F3. You have gliders, you may be using 3 gliders. Between everyone, you go and poke the apical portion. Aren't we causing more trauma or post-op pain? Because there's studies to show it. There's studies, new study 2020, where they, yes, not a big study of teeth, but on the cases that they divided, and the conclusion was that in the limitations of this study, maintaining the apical patency didn't affect the endodontic treatment outcome. So I'm not going to stand here and say, well, stop doing patency. But I just think we should take every case on its own merit and look at the case, look at the length where we want to be, ask the question, is there an periapical area? Do I maybe want the sealer to be in contact with that non-vital tissue to help stimulate healing, or do I want to stop just short of the apex? The effect of different glide path files versus taking hand files, pushing, winding it into the canal. Aren't we pushing more debris through the canal? For me, I want to rather get something that can pluck the tissue out. And that's where gliders come in, where it's a big step up, a big improvement on endodontics, where you actually have debris that you pluck out the tissue, whereas you use a hand file, because that's the first thing you do. We jump for a hand files, we jump for an 8 or a 10, whatever you believe of, and you wind it down and you go to length, and you get your length and you're happy, and you go and you block yourself out. And maybe it's all the result of hand filing, pushing it through. Studies to show that you can cause more debris extrusion with K file versus, in this case, a 1G file. Or studies to show that there's more post-op pain in doing hand filing versus gliders, the path file, because it plucks out the tissue instead of pushing it down. If you do it step by step, we don't take a glider and go from the top right to the bottom, but yet we do it with hand files, taking some glide, winding it to the canal length. So for me, this is a huge improvement and probably the best file in my armamentary. And people might disagree and fancy other ones. It's flexible, it's doing it predictably, very soft winding it. We have new metals that are softer, and you can see the way that these files are designed is that they cut in reverse. So it cuts 150 degrees backwards, 50 degrees forward. And because it has a higher tendency to cut backwards, it plucks out the tissue. So I can get a lot of debris out of the canal. So to throw another curveball, in a study that they've done, and they evaluated under micro-CT, Gouret's found that one root can have as many as 16 apical foramina. So how are you going to do an endodontic treatment believing that patency is the key for success? Is there a chance that you're going to do patency on all 16 that orifice? I don't believe so. I don't say don't do patency, but you might be patency on the one canal and the other might be still plugged. So it's all about the irrigation and the obturation in the end. Because let's face it, in the end, the obturation is what's going to make the success longevity was. All the rest that we do with filing, hand filing, all of rotaries, is to put us into a position to be able to obturate the canal after proper, good irrigation and cleaning. And that I can't stretch more enough. So I know lots of maybe histological and science and articles, but it's all great. I can sit here and I can tell you, we should be at the CEJ or the CDJ. We should be 1 millimeter short. We shouldn't do puffs. We should do patency. We should create our lengths not so long. How do we do it clinically? How do we take all that data, even if you have a CBCT, whatever you're using to predetermine what you do, how do you do it and keep doing it at the right length while we're prepping our canals? Now, a few years back, and I'm still proud of this case, I can show you this case, extremely curvatures, nicely sealed, obturated, but there wasn't a pre-op periapical area. Is that the norm, and is that where we should aspire to? If we are using newer sealers that are Bioceramics and that can stimulate healing, do we still want all these puffs through the canal by taking patency, going through it and through it? Or should we evaluate the case pre-op? This is a few cases that I've done of late. And for me, I don't know, but I feel more at ease in these cases where there's no big periapical area, where I just maybe 1 millimeter short of where I see on the radiograph with a 1 millimeter of sealer just in front of my cone, obturated properly, but respecting the biology, respecting the periodontal ligament. Don't try and get as many sealer pushed through the canal and say, oh, well, look at all the puffs, look at all the lateral canals, and it's properly sealed. You don't go and look for them. If you find them, great. I don't say it's bad, because I can show you hundreds of cases with proper bone healing, whether it was a vital case, irreversible pulpitis, and I puffed through the apex by using AH plus at that stage, and I can show you great post-op results. But I can also show you great results with cases running where there's no pass through, and it also heals. And that's, for me, respecting our biological tissue. Case like this, I don't know, I hope it's not freezing on the screen. Look at the Schneiderian membrane, how it's totally enlarged. Did the root canal, look at the bone formation, little droplets of pass through on the distal canal, and on the other ones just at length. And that's after 6 months of healing, where there's maybe just slightly, you can see prepped radiographically, maybe one more short of length, and a small little bit of sealer through that can stimulate healing. So how do we do it? Well, we have to determine the length. How do we determine length? Well, if the X-ray is still your only method of determining length, well, you've already seen that probably that's not the way to practice endodontics. And I'll make a bold statement, and I will stand for it, is that you shouldn't be allowed to do endodontic treatment without apex locator. If you don't have an apex locator, you shouldn't touch an endodontic procedure, because if the X-ray is the only method of doing this, and it's not an arrogant statement, it's just, it makes it predictable. Because if you look at an X-ray and you are aiming at that 1 mole, the problem is, where is that 1 mole? I'm all right to say, well, I need to be 1 mole short of length. The problem is, where is that 1 mole? Where is that 1 mole short, and how do we get there? But now you have a big sensor and you have a patient in your chair that looks like this. There's no way you're going to get a sensor in there, probably not be able to take an X-ray. So how are you going to determine the length if an X-ray is your only method of determining the length? Or this case, if you need to take an X-ray on this premolar, you're going to battle if you don't have a small film. Look at the frenum. It's going to keep your sensor out of there, and you can't use a pan, and you don't have access to a CBCT. So you can't use this as the method for determining that 1 mole that we aspire to. What about this? Patient was assaulted, he had trauma, plates, can take an X-ray. Is it going to help me? How am I going to do root canal treatment on this case if an X-ray is the only method to determine length, the length that I want to work on? Yes, it can help us. We can look at this case. There's maybe some resorption happening. I can take a new digital sensor. I can measure it on the X-ray and say, okay, well, I want to be 1 mole short of length. That's where I want to obturate and maybe deduct 1 mole. So I want to be at 22 moles of length. Yes, now I put my stopper on there and I'm prepping. I'm happy. I'm 1 mole at length. But what if this is the case? We already say that it changes throughout our life and that there might be more than 1 portal of exit. And on a lot of cases, you could see on young patients and at old patients, it can be as much as 80% difference of where the radiographic apex is and where the actual length is. So now you look at your X-ray from this view, oh, I'm still 3 mils short, and there's my mental nerve and I cause paresthesia because I want to be right there and maybe deduct 1 mil, and now you start filing and irrigating, and you're going to start irrigating on the mental nerve. So I don't think an X-ray is a very good method of doing length determination. And I think we are way too dependent on X-rays when we do endodontics. For me, it's about clinically my hands. That's the best tool that I can feel, and the technology that I use while I'm prepping. Look at this case, look at the mental nerve. I have to do a retreatment now. And yes, maybe by luck, I got it nicely on length, not so much sealer through. But look at that X-ray. I could have very easily maybe caused paresthesia by placing too much sealer through that canal, by doing patency all the time. And now I try and be careful, obturate it, and I push a lot of sealer through, and the patient should do a paresthesia. But you didn't have the CBCT view that I had, so I knew I was safe in doing this. So yes, CBCT is a great additive. It gives us so much more information, and I'm at a stage of my practice now where I take it for free, rather just to have the information before I touch my endo. When I'm the patient, take the CBCT. I want to know what's going on there, because I've seen so many anti-restive that has 2 canals or resorption or things that we just miss because we don't have the information at hand. So CBCT can be valuable, and it can help us determine there's external resorption. Patient, there's no area. You take a periapical, and it's all the pain due to internal resorption maybe. So CBCT is valuable, but you can look at study, and then, sorry, jumping a slide. We can even go as far to use CBCT with 3D endo software, which is amazing, and they are with 0.5 to 1 millimeter accurate, where we do these cases. And I showed them on my lectures where you take all the software and you plot it, and you can look and determine the length in 3 dimensions. It's amazing of what people think about how they do it, and with this technology at our disposal. But I can also tell you that it's not so practical. I still need to do it. I can plan it. I still need to do it. It's like placing an implant. You can do all the measurements and the size, but you still need to open up. You still have to be careful in doing it. So how do we do it predictably? Because I can also show you articles that show you that an apex locator is more accurate than a CBCT, but yet our X-rays is the method that we use to determine our length. So our apex locator is the GPS for doing endodontic treatment. It guides us down to that apical constriction where we will find the CDJ, and that's where I aspire to do my endodontic treatment to. Not looking at the radiograph, worrying about that's the length from the radiograph. I need to be 1 mil short. I want to prep to the CEJ. Every tooth, every canal on its own merit. Well, if you are using a apex locator like this, it was already made in 1969. Well, maybe yes, we can argue that it's not the way to do endodontics. And if you read the literature about this, the patients literally felt an electric stream when they placed it on it. So they felt a shock when they used this on a patient. So maybe that's not the way to go. What happens if we plug ourselves in and we clamp the hook on the corner of the patient's mouth? It doesn't measure a length, it measures resistance. So it's an electrical stream, and you have conductors that conduct the energy of the electrons, and we have resistors. And that in our mouth is the following. We prepped the canal. We want to be at the CDJ, the cemented dentinal junction, with maybe a little puff of sealer. That's what we want. How does it work clinically? Is the resistors is the cementum, the dentin, canal content, and bone. And the conductors is the periodontal ligament, where it will short out the oral mucosa and the file. So you want to use the two and accurately measure right to that sweet spot, and can sometimes be more accurate. If you take a patency file, push it through, it will short out because it touches healthy tissue. I pull it back 1 mil, and that's accurate. So this is how it works. And the sound is on. I hope it's not disturbing. There's 1 or 2 where I want this. Sorry, I don't know if it works, or I get a buzz in my head. I don't know. I hope it wasn't too disturbing, but you will see that it will go to length, go over, and I pull it back, and there's my length. So it is great that I can do that and that I can determine that constriction very predictably. And I can do it throughout treating it. But how do I do it with my hand file or the rotary file? I've measured it now, but now I have to do it physically on every canal, and I have to stop every time just on that spot. And I know all of you have done it. You've done this root canal, everything is going smoothly, it's going according to plan. And then just that last little touch that we give, there's bleeding in the canal. And then we've over-prepped it, or we strip perforated APC. So is there a better way of doing it in the modern era where everything is about technology and the advancements is staggering of what's happening? Can I just get a feedback from Kurt? What everything's still fine? You can hear me?
Yes, everything is fine.
All right. So next time you think about the apice of where you're going to treat, think about an apple. Think about the apical constriction is that is the center point. Sorry, Kurt, for asking. Can you see my mouse cursor? I just want to know that I.
Yes, I can see
the movement of my mouse cursor. Okay, yeah. Perfect. Thank you. So think of this as your constriction, where if I do apice, if I look at the terminus, and this is the file, we're going to damage healthy tooth structure by ripping the apex apart, or we're going to cause damage on the tissue at the apice and it could cause bleeding. We want our files to stop there with maybe a little bit of sealer that is biologically proved to stimulate healing, cementum formation, and think of this green area as the healthy tissue that can form cementum. And that for me is the ideal root canal treatment. So it's all good to have an apex locator, and I'll give you a few pointers to what I found can work or maybe can help you if you struggle with it, is to create a level surface. Even if you have to build it up with some opal dam, because once you start working, you're not always sure, is it now distal 19 or is it 18? So I try and flatten all my cusps. Specifically, if I know I'm going to crown the tooth later, why do you want to have the patient walk out with cusps that might cause pain afterwards when he bites on it? Just flatten the cusp and it will help you to be more predictable in determining the length. This is not a way to do root canal treatment. Without a rubber dam, a broken down piece, it's not going to work. Where do you determine the length? Is it now on this cusp? Is it now on the distal side of this cusp? You're just making it more difficult for yourself. So another key point in accurate length determination is rubber dam placement. And even if you take opal dam, just highlight that. Because if you work on a case like this and you take the distal portion, you might be on 16 mils. And we all know that our rubber stopper doesn't like to be on 16 mils. It's going to move up and down the whole time. You're going to struggle and you're going to find no joy out of your apex locator or preparation. And all of a sudden, there's bleeding in your canal. So now we've determined the length. We prepped, we flatten our cups to do everything predictably. And now we start prepping. And we do everything, we measure it. We are very meticulous because we are dentists. We like to be at that 1 mil. But after the third file with canal straightening, you might already start losing 0.67 millimeters. And yet I showed you studies to show that even 0.5 of a millimeter can be the difference of predictable outcome, proper endodontic treatment, or maybe a failure down the line. So how can we do it differently? By prepping and knowing constantly that we are measuring. Yes, we can hook maybe our apex locator clip onto the file when we do rotaries and see that we don't over prep it, but it's so easy to make a mistake in prepping. So one problem is we don't work with magnification. We don't work with loops or a microscope. And another, it's not just about the magnifying view. It's when we get older, we sit with presbyopia, our eyes can't focus. So now we sit with this tiny files and looking at it and determining 1 millimeter. We know how little 1 millimeter is, but that can be the failure or the success of our endodontic treatment. Now you take a hand file, I've created my length, and I have to place that on length with my file. But it's so tiny, it's very easy to make a mistake. There's a droplet on it, or you get your light that reflects on it. And it's easy to make that 1 or 0.5 millimeter mistake. And I jeopardize my case. Or we're using files over and over. Our rubber stoppers is not as elastic. And throughout our treatment, all of a sudden, there's a change of 1 mil in our stopper. or you bump the case, or you don't look at where you are. Is it now at the distal portion of my cusp? Is it at the mesial portion? And all of a sudden there's a change and there's blood in my canal, and I don't understand it because I've done everything meticulously. Well, what if I show you this case and I tell you that this case was used, and you have to take my word for it or phone my assistant, but I predicted or deliberately, this was the X-ray that I had pre-op, and this is the post-op X-ray. This whole root canal was done without the use of any hand file, without creating patency, without touching a rubber stop, and with no pre-op determination of my length. Do you think it's possible? I knew there was endo, and that's how I trust. And I can tell you now that I started doing endodontic treatment on probably 60% of cases where I barely touch hand files or go at the last bit and maybe do a patency file. And I know it sounds crazy, and I'm not advocating go and leave hand files out and start prepping all your canals with this, but that's the value of technology, that we can do a case like this without any of the above, no patency, right to that apical constriction. So how can we do it? So there was the only X-ray that was taken with the cemented with the GP cones, and I was actually surprised to see the curvature, and it was quite a difficult case, I'll admit to it. But I was determined to show it in a case because that's what I've been feeling the last 2 years of a new instrument that I use, and it's probably the best game changer in my endodontic career. And that's to use an apex locator driven endodontic handpiece, where I don't want to be fooled by the one mold. I want to know in every case, where's the CDJ, the apical constriction, and for every case, for every canal, it might change. Even though the X-ray might show the mesial and the distal canals are both on 21 mils, it might be that the distal might just be that 0.5 mils shorter. How do we do it predictably, and what is this all about? Well, if you think that it's impossible to use an endodontic handpiece with an apex locator, well, they've already made cars way back with Distronic, where it's way more advanced than just speed control, where it will pick up the car in front of you, and the car will automatically stop itself at the predetermined distance. To tell you, I'm 20 meters, I wanted to stop, the car will stop itself, or you drive in traffic, all of a sudden, it will hit the brakes automatically. So we think about aeroplanes that can auto land, a plane full of people with safety. And we have cars that can drive at a speed of 120 behind another vehicle and automatically senses it and stop. We can be there in the medical field, that we can do endodontics with electronics that can stop us and guide us. So I am fortunate to have two handpieces in my practice. I have the Endo IQ, and for long we were pleading about the Propex IQ that will come out with the handpiece, which can connect Bluetooth to my iPad, connect Bluetooth to my handpiece, and then it measures throughout my canal. While I'm busy prepping, it measures the whole time. I'm the whole time aware of colors and sounds, and I know at my predetermined length that I can put the stopper on reverse. If I touch the CDJ, I touch the constriction, the file will reverse automatically. And it takes over control, and I don't have to guess the whole time of where I am. There's another one on the market that's out from Axis is selling this one, the new one from FKG, which has the same function. I think it's also a nice handpiece. And then I have this one in my practice, the 8 Chief, which is a great little tool. And it's one that I got from IDS in Germany before it was launched in South Africa. And I can tell you that it's the best game changer in my endodontic practice. It comes preloaded with lots of file systems, and it's not about the file system so much, but what is nice about it, you can put it the same as the Endo IQ or the other one. All you need is the speed and the torque, and you can set any file onto this. What is also great is that it has reciprocating, and all the others have reciprocating. So if you're using Wave 1, which is my file of choice, which I have so much joy of, I can put it on reciprocating, but this is what defines this specific handpiece from the other two, is that you can set more functionality on the tip of the apiece at the predetermined length. So at AP you will be short, so I would normally take it 2 clicks back, and then I can tell it to either at apex, when I reach this predetermined length, the file must stop. So it will stop there, or put the file on reverse, or slow down, or you can put it off. So I alternate between stop and reverse. I won't go for stop straight away, but this is how I play with it. So if you put it on stop without going down, I do a crown down technique. I use my glider with lots of glide, and I would go in, touch the tooth, plug it out, touch, plug it out. I would take a CBC to pre-op, and I would see that the canals are open. If the file doesn't go and I don't get the sound at the predetermined length, then I would start using a hand file and make sure that I don't block it out. But I can tell you now, probably in 50 to 60% of my cases, I can do 2 or 3 motions with my glider, right on length, it will reverse, and throughout I will keep it open. I would change, if it's a big canal, to the stop function, or I would put it on reverse, and it's absolutely amazing. You can take it like a feather with your hands, you will work, and it will sound beep, 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 and if you reach the apiece at that constriction, it will automatically push you out. I don't know if you worry about my rubber stopper, it will stop dead on accurate where I want it. So I've placed the sound on to get the idea of the sounds. I hope it's not more confusing or irritating, but you will see the motion of working, reciprocating, and that's also what I like. And then you can see all of a sudden it goes into reverse. I will play this again. And that's what I like about the system even more, probably because it's reciprocating. It's so fine and minute. And as soon as it touches that apical portion, look at the file, it reciprocates, it will touch the length, and then all of a sudden it will start spinning, and there is no cutting happening, and it pushes you out of the canal. So that's the reverse function, which is great. All the others have this, they don't have the stop function though. Let's see, glide path. All of a sudden it will start spinning and push you out. Or I can use the stop function. If I've been to length a few times, instead of a patency file plugging through the whole time, I will take this, make sure that every time I'm on length, because if I don't have patency, or in patency I mean that the file will go to length, it won't go to length, and there will be a difference in sound, and I will then start using hand file. But that's quite amazing. I always put glide on. I started using less liquids. At the end, I have a very strict irrigation protocol. I'm not going to get into irrigation, but while I prep, I can't get fluids in a canal in any case. So I take glide, because glide lubricates, emulsifies, and holds the debris there. And as soon as you put sodium hypochlorite on the glide, you get this bubbling effect. So it bubbles out the tissue. So the file is plugging out tissue. I will constantly clean my fluids. I will constantly irrigate between going down, not just take the file and push it to length. And when I know I'm more or less close to length, I will softly guide the file, and I will feel it will go to length, and it will softly reverse me. And I can do that 1 or 2 times to make sure that it's clean. Irrigate, then I'll go to my next file. So factors that can give a false reading with the handpiece, but also with normal apex locators, is sodium hypochlorite creates free oxygen. And when you're on a multi-tooth canal, sometimes it's too much and you get false readings. So suck out the most of the liquid so that only fluid in the canals, not in the pulp chamber. If the file is too small, you're working in a big canal, that can also be a problem. And that's why I like, instead of the fluid glide, so that it fills up the space and it makes it more predictable for me. Obviously, amalgam fillings or metal can short out the file, and then it gives you a false reading. Zirconia crowns doesn't affect it at all. So to bypass it, you can take a bit of opal dam, isolate it, or you can take a bit of plumber's tape, put it around the file, and that will help that the file doesn't short out when you are on length. And I can't stretch it enough. We've dealt with it through COVID a few times. It was dealt with last night. Rubber dam. Otherwise, you get clavicular fluid through, and it's not properly isolated. It will give you a false reading. So you have to make sure that it's not just rubber dam, but also opal dam around the tube so that it's properly isolated. Also, mirrors is nice, and Pierre touched on it last night about these high-res mirrors. I use them myself from Equity Dental. They are amazing, but beware that these metal, if it touches on your handpiece, it will give you a short out because it touches metal. And I found these small ones, the size 2, to be amazing if I work on an upper 6 or an upper 7. There you can see it's a small file, easy to locate the MB1, MB2. I have space and freedom of movement for my mirror, due to the fact that I can keep it out of the way and I don't touch my hand file. Another great attribute of this file is this endo finisher or the shaper, something that I use only when I do retreatment and there's sometimes tissue plucked or debris stuck, I love to use this. In the beginning, I hated it because I created so much bleeding, because the file expands and shrinks over a 4 millimeter period, and then you keep it 4 more short, and all of a sudden, there's blood in the canal. And if you look at this animation, it will move, and you will see all of a sudden the file there will peep through the canal. That's what happens clinically. So now when I put it on stop and I activate it, it spins at 1,000 RPMs, and it stretches, elongates, splits short. It's like a scaler cleaning the canal, but it will stop dead. If I touch that periapical area, all of a sudden you can see on 1,000 RPM, whoop, there it stops, and it makes it safely that I don't over-instrument the canal. So the case in the beginning, that's why I know, and that for me is not looking at X-rays, but clinically, and I hope it's not irritating the sound, or you must tell me that I put it off, but you can see there's the file, listen to the sound, beep, 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 all of a sudden it pushes your back, I know I'm on length. And then I will prep the canals, brush cut it, clean it, irrigate, and then when I'm on that last 2 or 3 mils, you will push, and you can see what happens with the file. It's not even short at length, but it's really, it feels like someone is pushing your file out of the canal. It's amazing. The feeling in the beginning is actually strange, but you learn to touch it with your hand, with 2 fingers. You will go down the canal, and all of a sudden it will push you back out of the canal. And then what do? Did I prep enough? So this is what I do. I would take a 90 flex file. If it's prepped to a size 25, it's a normal 2% tapered file. You get them from Dentsply, they are extremely flexible. So they don't cut, you can't file with them. They're not easily pre-bendable, but it's easy to just feel a canal. I can place a bit of glide on it, and that I will go and I will feel. I don't know if you hear my apex locator. I will turn it at length, and it will show me I'm on length. There I'm on length for the apex locator. And then what I do, I tap with my finger 1 or 2 times at the back. If my apex locator stays stable, I know I haven't over-prepped it, and I know I can obturate with a size 25. If I use it, the same method, I don't know if you can hear it, or I don't know, will you beep, beep, beep. I'm on length, I tap it, it makes did, so I'm over-instrumented, pull it back, then I know I have to prep bigger, and I can go, and I can feel that I'm just at length, and if my apex locator don't short out, I know I've prepped it enough, and I can obturate the case. I really, it's a game changer for me, so that I pre-op evaluate where I can place either as a stop function or activating it, but in between, I activate vigorously. You can't do this, and that's not for every case, but a lot of these cases you can do with literally no hand fast. Or at the end, I would maybe go and do a little bit of patency, but I don't do patency all the time, every time, especially if pre-op I determine that there's no periapical area. I don't see the need to go and plug it through, but you have to be meticulous, and I wouldn't say don't do it, but use all these alternative methods, and don't be so dependent on the X-ray and the 1 millimeter where you want to obturate on. I make use of visual inspection as well. So I love the Endovac system, where if you look here, you can see when I suck in the one canal, both canals clear. So it immediately gives me information to know if I'm going to place my sealer, that I want to see the sealer moving on the other side. If I push it up and down, you will see the sealer will move. And I make use of paper points instead of just the X-ray. So if I do this, I use a glider, and I started using the yellow file more and more, and not try and force the primary file, although this is how the system is intended. I take my glider to length, activate, irrigate the whole time, and every time between my files, I would take my glider again to length, make sure that the apex pushes me back. I know I'm at length, I know the tissue is out, I know it's clear, and then I irrigate in between, and I will go back. So it's just a different take on things, and that we're not just stuck in the ways that we do it, and forget about 1 mil. It's not about 1 mil, it's about every case on its own merit. Activation, 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 and irrigation on the end. That's the success. So I would have a strict protocol, how I irrigate it, and then I would obturate it. And then also I make use of paper cones. If I have blood on the tip of my paper cone, I know, well, I might have over-prepped it. So I will take another one, see if it does the same. I will cut it off, place it back. If I don't get blood, I know, and I will take that back to my GP cone, and I would cut 1 or 2 mils off. Because even if it's short, if I can place a bit of sealer at the apical portion, I know I'm all right. because the sealer is in the end what creates the success. So CBCT gives me information. You can't go and do this if all the canals are blocked and calcified. You know the cases where you go in and you can take a 10 file or an 8 file, 1 to 3 in your own length. I can now do it with a glider file without a hand file, and it's taking out tissue and not plugging tissue into the canals. And I use new files on every case. You can't use files over and over because otherwise you are going to run in trouble and the cutting efficiency decreases. So maybe also a very important aspect. And then, is there a periapical area? If I have a periapical area, I really would go and then focus on patency, focus to get my sealer to length so that when I obturate it, I just feel that a little bit of puff of sealer stimulates healing. And through the cases, through the literature, that seems to be the norm. And I'm sure there's lots of guys out there who maybe experience the same, where with cases where I have only vital tissue, no huge periapical area, why do I want to go and create all these puffs of sealers right through the apical portion if there is an immune response which can take care of the rest? So you will see articles saying, yeah, but the dentinal plaque is full of bacteria. That's where we have immune response. And if you keep it clean, if sodium touches that, and that's where irrigation and maybe the endovac, we are circulated a lot, making sure that it's clean, using all these aspects and visual information to get to the end result. So I'm just going to touch quickly on a few tips on obturation. I know we stretch for time, but we've prepped the canal, now we want to obturate it. Is a GP cone doing anything? And maybe Chipper, you can just run the last poll for me, please. So how many of you are still using thermofill or Guttacore in your practice? Don't use it 20 or 50% of cases or 100% of cases. Okay, everyone should have voted. I can share the results, Chipper. Okay, 20%, 100, do not use it, 66%. Well, I love to use it on curved canals, but I really haven't done a case probably the last 2 years because I really, if you prep properly with newer, the file systems and the GP cones that's available, that's machined, I don't see the need for it. That's obviously what we don't want. And how can we avoid this? Luckily, there was no paresthesia. We all have seen cases in the literature. I've seen cases myself where there was sealer in the inferior alveolar canal. So we prepped it, but we can only prep the middle portion depending on the configuration of our file. So in the end, the success, we've prepped it. We need to obturate it now. Irrigation, and then sealer. That's the important aspects, and then the coronal seal. So the ideal for me, GP cone, 1 ml of sealer. And if there's a periapical area, maybe a little puff, that's fine. And I know all of you sitting out there have a favorite sealer in your cabinet. I know you can all show me great cases of success and failure, and probably have also meant their success and failure. So it's probably not about, sorry, I'm going to skip this just to save a bit of time to determine. I don't want to be specifically speaking about sealers. So what we obturate with is we have 3 methods. We can have a single cone, carrier-based thermofill or Guttacore, or continuous wave. So what do? We don't want this, I'm sure. So single cones. Does GP kill germs? Well, I'm sure we all can agree that a GP cone can't kill any germs. So it's about the sealer that changes the pH, binds onto the structure, and that we can get cementum and forming and hydroxyapatite that gets into contact with the fluid in the tubules. So GP cone is only there to fill up the space, and that's why we use sealers like AH+, and you could get a much better result if you used a continuous wave technique where you will burn the GP to melt it so that you have less sealer in the canal so that the spaces are filled 3-dimensionally. So it's all about the sealer. And now on single cones, they have these new co-formed GP cones. What is nice about it, they firstly machine, they're not hand rolled like a lot of GP cones. so they are more accurate. And also what is nice about them, that when you bend them off, even at the orifice portion, you will take the heat down 3 to 4 or 5 mils in front of it, so you have a softer cone taken downwards. And that has changed it, because you can see the tapers are smaller, it's easier to fit them, and I don't have such a high force of GP cones going down the canal. And they are variable taper. Obviously, you should use a GP cone for the system that you use. If you're using constant taper file, it really doesn't matter which system you use. A constant taper 4 or 6% will be the same. You can use an Endogauge, and I dare you to take something like this and go and measure your GP cones, specifically if they are hand rolled. So many times you would take a 25, you will place it through, and you will see that that GP cone actually is longer than what it says, and that's what causes bleeding. So you can determine this with this new type of files. That's something I really don't use, because they are very within 95%, they're accurate, the GP cones. And I would rather take my paper cones and see if there's any blood on my paper cones. Our GP cones, we touch it, it lies in our cupboard, so maybe sterilize it by taking the GP cone, placing it in sodium hypochlorite before we use it to obturate our canal. So I like to squirt a little bit of sealer in my canal. This was all the cases of AH+, but I can only use, because it's a thick tip, I can only use it in the orifice portion. And now I have to get it down to that bottom line, or the tip, or the apex where I want the sealer. So one thing that we can use is take the last file that you use, and you can spin it in reverse to length, so that I know I smear all my side walls, and then I would place a GP cone in the canal. Now, if you look at the literature, and specifically with bioceramic sealers, they're calling about a hydraulic condensation technique, where they still use a GP cone, and they will push it down, and the force of the plunger will actually create the sealer to go down. But remember, they use files that aim at creating a tip size of at least a 30, and they're using constant taper GP cones. So there's much more pressure on it. If you're using a 20 or a 25, which is smaller in taper, you're not going to get the plunger effect, and you're not so determined on the plunger effect in, say, for instance, AH+. So you can still get lateral canals, so it's not dependent on the system I use. I've seen lots of cases of single cones, by properly just placing them, having enough sealer in my canal and placing them, you won't push as much sealer through. You can take a paper cone, or you can place the GP cone in. I will show you what I do, and just make sure that there's not too much sealer in my canal space. So with bioceramic sealers, it's a game changer for me. I'm not going to speak about products, but I started using the total high flow in my practice after I started using Trinatomy, which is a very tiny system on cases, and I knew that I was a believer in continuous wave burning off GP cones within 3 mils of my tips, but I didn't have as much control over the amount of sealer that I would squirt through the apical portion. So with bioceramics, I have quite a high success rate in cases where I use MTA, and it's just normal. If you look at the literature, how it's osteoconductive, how it stimulates bone healing, how it can create formation of a vascular system. It has a 12-year track record, and I really start loving the system. It changed the way I do endodontics. I will say, though, that I've seen lately a lot of bioceramic sealers on the market, and everyone is jumping on the bandwagon. And I can't say the one product is better than the others, but I don't know if they all have a track record. And it feels to me like toothpaste, where they say, well, it's whitening toothpaste. And we all know that toothpaste doesn't whiten teeth, really. So be careful on what you select, and see that you use a product that's trial and tested, if that's what you like. The principles of angiogenesis, creating it's not so dependent on blood. So if there's a little bit of blood, it actually can stimulate healing and stimulate cementum formation. And it really changed endodontics for me. But they have very big tips. And to get this to work with the wave one system that I use, I had to change something, because the needles that they use just squirted too much sealer into the canal. And I couldn't get the sealer right where I want. And I really don't want to go with files afterwards and go and plug sealer through. Maybe if there's a periapical area, I would do patency at the end, where I know I have patency all over, but to make sure that I get a tiny bit of sealer through my canal. I used a Trinatomy tip, and I will cut 2 mils off. Now I can place it right at length, plug it back, and slowly squirt out a little bit of sealer. And I told you, I'm making use of visual inspection of my canals as well. Using magnification, you will see here that the two canals join. So automatically, if I place my sealer, I want to see that the sealer actually comes up in the adjacent canal. Then I'm not so dependent on where my GP goes on the left or on the right, because the sealer is what's going to heal it. And then with a bioceramic sealer, you literally can fill up the whole canal. Without a GP cone, it will set it will heal, but it's too expensive to use. So you can see if you look on the right-hand side, it's a small tip. I like the flow rate of it. You can see the sealer right at the apical portion of it. There you can see the sealer come up. And then I'm not so dependent on the apical fitting of the GP cones. I know it will fit, but by doing that, I know I won't squirt out too much. As I place it, some sealer will get up, and I just take a little bit of the top, burn it off, and condense it. Well, there's an MB2 canal. So if I know that the canals are merging by working with my handpiece and knowing with my glider file it's connecting, why do I want to go and prep to a size 25 or a 30 on my MB2? Then I will just go to a size 20 because I know the other canal is open, there's a communication, and I can seal it off with that. So what I also would do with any sealer that you use, place a bit of sealer in the canal, you can place it on your GP cone, go to length, and then take out your GP cone and inspect it. If there's enough sealer around it, it's fine, you don't have to add. If I place my GP cone to length, I always twirl it around. I don't just take the GP cone and place it straight to length. I will twirl it around, I will take it out and inspect it. If I see that there's not enough sealer on my GP cone, I will then go and place a bit of added sealer just on that portion and then reinsert it in the canal. And then I know I haven't over placed the cement and there will just be enough in the canal. Because it's like a room with one door, 100 people, all of a sudden the clock goes off and all 100 wants to run to the exit. You won't find that everyone will bottleneck. So if you prep correctly with tapered files, the sealer won't go down to length and squirt out of the canals because it's tiny tips. It will just touch the apical portion. You might get a little squirt through, the rest will come up in the canal. If you over prep the canals, then you will create lots of sealer and lots of puff. So maybe another tip on single cones, if you want to place a post, you can take a scalpel, just give it a small cut that it's just not through. Because we are tucked back, you can go to length, spin it in the opposite direction, and it will break off and you don't have to go and burn it off. You don't have to go and create a post space. So there's maybe another clinical tip for you just on using single cones. If you have a very bended canal, you can go and spray some endofrost on it, ethyl chloride, your system can slate, and then it will stay in a curvature and you can use a normal single frost. You don't have to use all these obturated methods that is expensive sometimes. So tips that I can give you if you are using carrier base, I see there's a lot of you using thermoform or Guttacore. With thermoform, you have a plastic core. With Guttacore, there's GP in the core. So with thermoform, what I would do is I would take a glass of warm water, place the tip in it, take a scalpel and just strip a bit of the GP off it so that you know where the plastic core is. And then I will stay 1 or 2 mils short of my length because it will squirt through and it will avoid you having huge puffs of sealer through the canal. And especially in cases where there's a nerve close by, I will avoid that at all. So I'll strip it, but I will stay 1 or 2 mils short of the canal. A case like this, there's no way I will use thermoform or Guttacore. So with Guttacore, and this is what happens, you can see how high the sealer puff went through. So imagine you're on an inferior alveolar nerve or the mental nerve, you are going to run into trouble. So how do we control this if I use Guttacore or thermoform? So with Guttacore, set it on the medium, the first setting, not higher because it will start bubbling. It's softer than thermoform. I like the Guttacore, specifically the pink one more, which is a bit harder. And the clinical, make sure that you don't try and break it open, just click it, make it open, don't click it out, otherwise you break them. And I would take the stoppers off and I will mark it with a Koki pen. With thermoform, it's a bit difficult because you need a specific drill to do it. With Guttacore, you can take, once it's coming out, you can take your artery forceps and you can just break it off. So you have a shorter stint to work with, which is easier to place it. But in cases where you're confined for space and you don't cut the stopper off, then you bug it, you can't get the stopper off. So either cut them beforehand so that you can take it off, so that you have access to the other canals. But as a general now, I would cut them off total, mark it with a Koki, stay 1 mil short of my working length and place it in the canal. So the best clinical tip is, how do I place this to avoid too much sealer going through? I will speak to you and then I'll show you a short video. You take sealer on a paper cone, which you've cut 4 millimeters off. So you take a new dry paper cone, cut 4 mils off, take sealer, place it in the canal, take another dry paper point, and then go and place it in the canal. So what it does is it will take the sealer to your apical portion and it will take out the excess of the canal. And then you slowly insert the Guttacore and you will avoid big squirts. Another tip is, if you're using verifiers and your verifier at length can't turn, rather go one size Guttacore or thermoform smaller. So if I prep to a 20 and I find that my verifier struggles to go to length, rather use a yellow Guttacore, vice versa. If a 30 doesn't go, take a 20. You will still have enough sealer, but you will avoid pushing too much GP or sealer through the canal. So this is what we do. You take almost to the end, and then I'll address some questions. It's quite daunting speaking to a computer. I don't know where everyone is and where they are listening, but we're almost there. So take a paper cone, cut all 4 mils, take a dry one without sealer, take the excess out, and then slowly go and insert the Guttacore. And when you push on the side, you can really break it off with the excavator. So this is cases that was done with Guttacore. You can see the pus, but you can very easily squirt this into a mental nerve or a inferior alveolar nerve or inner sinus. So I avoid using them. It's really only extreme curvature canals where you can maybe use them. So to do continuous wave, you have a plugger and you have a handpiece that can heat the GP. So this is products on the market, also from the ATF company. Spartan Access Dental are selling them, and the new Gutta Smart from Dentsply, where you have a handpiece. And clinically, if you're using any type of bioceramic sealer, I can tell you now they don't like heat. I don't care if they say it's more conductive for heat. You can't use a bioceramic sealer with thermoform or Guttacore or go and burn down. If you use any of the bioceramic sealers and you're using a plug down, put the heat to 150 or 160 degrees Celsius and not the normal 200 degrees Celsius, because it really takes the moisture out of it and the cement starts crumbling and they are ineffective. Also, when you place the sealers, that's why I stopped doing it. So if you take the heat down at 200 degrees Celsius, you can burn the periodontal ligament and cause trauma. So if you're not careful and meticulous, it's very difficult to use these systems. So you will take the plugger, take it to within 4 mils of your working length, leave it, then it cools down, activate it again, swivel it, plug it out, and we'll plug the back GP out, and then you can use the backfill method, and you can squirt the GP backwards. Don't even try this if you don't have magnification. Speak to someone who sells it, like Zoomax, that they have microscopes. To David DeBell, you can probably bring you one. If you work with a microscope, not just for endo, for anything in your practice, you will definitely not work without it again. But don't try any of these methods without magnification or a loop, because you can't see where you've burned off the GP, and it makes it impossible to backfill these cases. So with these handpieces, that's the old Calamus one, it really softens the GP, and you can get flowable GP that you place within the canal, and especially if it's wide, oval-shaped canals, you can fill it up. You get the idea. There's even new bioceramic pallets. So the difference between the ATF and the Obturation, it works with pallets, and the ones from Dentsply with their own compules. There's also now bioceramic pallets for what it's worth, where it's clinically relevant because GP doesn't kill bacteria, but it says that GP will bind and bond with this bioceramic sealer better, and it makes for a better seal. So if that's what you need, so you'll burn it off within 3 mils of your working length, and you will squirt the GP backwards and fill up the cases and condense it. So now with the newer GP cones, I don't have to burn it off so much because the heat conducts 4 mils further. I will just take the orifice, burn it 2 or 3 mils below my orifice, and then I will press quite hard, keep it there that it flows. And for me, that's more than enough. And then I don't have to go and backfill all the way. I've done a few cases in my career which is called squirting, something you will read about, where I can do a case like this without any GP cones, where I would place my sealer and I can literally go place the flowable GP within 4 mils of the working length, make sure that I have a plugger that can reach within 2 mils, and I can press hard down on it and it will flow, especially if there's very strange anatomy, but it's not something that I use. I sometimes use it on anterior cases where I don't find a GP cone in those cases, and I know it's very overly shaped, and to avoid lots of sealer, I would place the sealer and then literally take a case like this and do this. You can see it's irregular there, but it's shaped just with flowable GP. No master GP cone is placed in this canal, but I don't know if this is at all relevant in the modern era. This is all the cases. So when would I use which one? Post place, oval canals, maybe the calamus, but now with new bioceramic sealers, we don't have to shape and force down GP to make up space where the sealer will shrink, because we don't want sealer to shrink. And with the new bioceramic sealers, when they touch the healthy tissue, it will form cementum, what we want. So Guttacore and curved canals, if I want to place a post, don't even think about it. Or if you use calamus and the type of sealer that you use that is advocated for heat, if you can't reach within 4 mils of your apical portion, you're actually doing a single cone. So then I would avoid doing that. Cases that the canals are close together, place a paper point in the one before you place it in. Otherwise, you will block yourself out of your canal. Magnification, high resolution mirrors. You can see there's 2 canals very close to each other. There's no way you can use Guttacore or thermofill in a case like this, where I would rather downpack them and backfill them. Case that was referred to me, you could see clearly a second canal. The doctor did a great job on the first canal, but with CBCT, the one canal was missed, and it was obturated with burning it down and backfilling it. No way she can do this with Guttacore. So avoid these Guttacore or thermofill at all close to your nerve. You don't have as much control over the placement of the sealer or the GP. And for me, the cutoff is 50. If I have to prep bigger than a 50, I would use MTA. There's no ways I would stop and do GP cones, because I don't think you can split properly if you prep bigger than 50 sizes with GP cones. That's where is my cutoff. And then I would use MTA. And it's I'm sure within a short stint, I will probably also bring out MTA type sealer. I don't know, because the MTA has been trial tested. It's an amazing product, and I really have great success with the MTA, and I hope to see a sealer with the same properties soon. Cases like this, impossible to seal with GP and just sealer. You will have to use the map system and place it down. I'm not going to play the videos. Measure your stopper within 4 mils. Magnification important. Cases like this, no ways that you can seal this with GP, but measure your plugger. And then a clinical tip, once I place my MTA, I would take the ultrasonic scaler at the back, just tap on it and irrigate so that I condense it like a plugger right to length, and it makes a very nice dense apical seal. And then I can backfill it with flowable GP or with my core build-up material straight away. So to conclude tonight, and I hope that I aspire you to maybe something new, and not be so dependent on just 1 millimeters and X-rays, but rather to do it more predictably, constantly predicting what you do and know where you are in the canals by using and employing technology. A case like this where 1 more short wouldn't have done it. I had to over prep this, so I used MTA on the one side. There was no periapical area, and you can see the healing 6 months post-op. On a case where there's a big periapical area, I would use a GP cone short, but I would really try and maybe get a puff of sealer through, change the pH, and it just feels like it stimulates healing, and start focusing on my sealing rather than all the prepping. For me, there's 2 successes in endodontics. One is irrigation, and the one is the sealing afterwards. If you don't reach your apical portion, yes, there's other things that's important. We all know how difficult it is sometimes to negotiate your length, but you have to then sit and use C+ files, negotiate them to length, because the theory also showed us that when we are prepping short, 2, 3, 4 mils too short, we set ourselves up for failure. And this is with new technology, with the Apex locator that I will definitely buy after tonight. Phone companies, I know there are specials this week on the endodontic handpieces as well. And get yourself, if that's not in your armamentary, put it on your bucket list so that the next buy is maybe Apex locator. And if you have not one of the 2 and you fancy endodontics, invest in an Apex locator endodontic handpiece. It's the best tool. It changed my endodontic career, and I can't wait to see what new technology will be there in the future. So a case like that, where I used probably all about the things I spoke tonight. We haven't touched on irrigation and the things that's also important, but maybe think about your endodontics as a tool. Think about that apple that I showed you, and that we prep conservatively, seal with more predictability, and get more joy out of your endodontic procedures. Thank you for listening tonight. Thank you, Kurt. I'm here for questions.
Thank you, Dr. Dippenaar. I just want to go through some of the questions here. I'm not sure if you can see me. Can you see me?
Wait, let me just unshare my screen, maybe.
Okay.
All right.
We've got, does the apex locator reading correlate with the apical constriction in all cases?
Yeah, most of the cases, that's the predictable way to do it. So it is, there's no other way of doing it, because you're not going to know with your hand file where you are. You can't make you just take the X-ray and take it and say, okay, now I'm at the constriction. It's all about feeling, but the apex locator gives me that feeling, and in the end, the one thing that will tell me I've overprepped or not is a paper cone. So the two must be together, and the whole time I will work. So in a normal case, I just showed you that it's possible to not use hand files, but you have to use them all in conjunction. The whole time it's about feeling. You can't be just do a measurement in the beginning and that's the measurement throughout, because I showed you that it changed throughout, and that's why I like this, because while I'm working the whole time it's measuring, and that's the most accurate way that to date we can use, because that's where we find the PDL, and that's where we it will short out.
Another question is, how would one determine the correct length with an apex locator less than 1 millimeter?
Well, again, don't think about 1 millimeter. Think about the apex locator. So the question is great that yes, the apex locator. So the most accurate, if you are uncertain, is take a small file. Don't use a 15 or a big file. Take a 8 or a 10. Take it to length. If you see it shorts out on your apex locator, that's at length. Pull it back, and that would be the ideal length. So if you pull it back and you see, okay, my apex locator doesn't show, I'm over, you get that beep and it will say beep on to, I pull it back, that's where I measure it. And that is the 1 millimeter. Let's say that's the 1 millimeter from the apical constriction, and not anything to do with the radio of the X-ray.
Okay. Another attendee asked, does the use of biomimetic root canal filling material make the location of the apex irrelevant? Does the use of the biomimetic?
No. Bioceramics, probably you'll probably ask bioceramics. No, it is still relevant because it is osteoconductive. It forms some bone cells to come to the area. It increases the healing because the pH is what it goes to a 12 or a 12.5, and the pH is what kills the bacteria. And I showed you the cases where you're 3 or 4 mils short, it had a worse outcome than when they were 0.5 short. So it is still relevant, but I would focus more on it when I have a huge periapical area, because then the sealer can actually help me in healing. But when there is a PDL that's healthy, we have healthy tissue at the apex. Why do we want something to push through? Because there is no area that we just want to kill the germs inside the canal. So we want to stay within the canal and not over-instrument it. So it is relevant, but yeah, I hope that answers it.
I'm sure it does. If I clean all the canals thoroughly with good irrigation, why do I need to fill the canals to the apex or even anywhere near the apex? Can a good coronal seal suffice as a good measure of success of a root canal?
Well, you've seen the problem in your own cases. If someone comes in for a year, there's no area, they close it. A coronal seal is important because where does bacteria come from? It comes from the coronal portion, it doesn't come from the apex. And Martin Thrope and then done studies where they showed they had a good endodontic case, but they have a poor coronal seal, and then they done cases where they done a poor endodontic treatment with a good coronal seal, and it outperformed it. But that's not the way that we should do it, because the sealer is there to create, what it does is the pH, which is important, and it actually binds to the tooth structure. So it forms cementum. And that's what's important. And there might be lateral canals or tissue. So it's a valid point in the coronal seal, but that is just an add-on that can help us. Your chain can only be as weak as your length. So I can't say, no, prep foremost short, seal it properly, because what do you leave behind? There might be dead tissue, there might be plugs. So no, you have to fill it, but it's a conjunction of that plus this, obviously the coronal seal that's important. It's a very valid question, and the coronal seal is probably one of the most important things after irrigation and obturation.
Okay. Chris asks your thoughts on the new Bio-C sealer from Angelus.
I don't want to, that's what I said, because there's quite a new ones coming out, and there's a new one from New Dent, I think that also has great research now. It does a 7-year track record. If I look at the new Bio-C, honestly, I haven't used it myself. The first one, the MTA Fill Apex, I've used it and I tried it. I hated it. It smelled funny. It had a dual mix syringe. It was very sticky. I couldn't work with it. The new one comes pre-mixed. So that's what we want. There's a pre-mix one where you don't want it to mix, and that hydration is what is important. If I look at the box, it says patent pending. So I don't know really what that means, and I don't know what's the trials and what's the study. So firstly, what I do, I look on the internet, just as you do. I haven't developed any of it, so I can't comment because I haven't used it. I will, and that's where I'm scared to say, because the SADA seal, there's lots of them on the market that come out. New names from all the companies are bringing out bioceramic sealers. Are they trial and tested? They probably have been, but they don't have a long track record. And the Total Fill, or the new one from Bradley, that's now a 12-year track record with great cases and shown. And for me, that works. And I'm leaning to something that I know has scientific data and also clinical trials behind it. So that's what I wait for. I can't say it's a good or a bad product. They obviously are well researched and they do it, but I haven't used it, so I can't comment anything other than that.
Then Mari asks, which sealant is the best?
It's impossible to ask. I just think there's quite a new movement towards bioceramic sealers, but that's also why I said it in the beginning. For me, it feels like whitening toothpaste. Everyone is bringing out a whitening toothpaste and a whitening mouthpaste. Are they all doing what they say it does? I don't know. But that's for me. And I think for clinicians who's not as experienced, I think the new bios, because we've been preaching it with AH+. It's an excellent sealer that I can show you great cases with lots of puffs, and it all ticks the boxes and it works. But if you just do single cones with that, it's not as effective. Where you probably, if you can't backfill it or use Guttacore or Thermofil, you may be better off in using a sealer. Because I would ask myself the question, if I fill a tooth with just a sealer without a GP cone, will that sealer set? Will it sink or won't it help? And if you can answer that, then you know you're on the right track. But it depends on the obturation method. If I use a bioceramic sealer, I can get it nicely to length. It's not so dependent, because what the GP cone then does, it actually just is a space in which I can retreat them, because it bonds to the side structure where the other sealers just fills up the space. It doesn't physically go and bonds onto the dentil, and it doesn't stimulate dentine formation. So there isn't, it's difficult to say this one or that one. But again, look at the literature and then you see, compare it. Type in the Google. We sit here every night. I know Prof. Peter gave a lecture last night. It doesn't fall out of the sky. We use Google the same as you. I don't even have access to the university, but I have to thank Martin Foster, who's at the university, and I sometimes phone and say, listen, I don't have access to this article, and he will gladly get it to me, and I'll read through it. If there's something that I want to know, that still is where you can find the answers, where there's clinical trials to see, does it work or doesn't it work, and what does other people say?
Okay. I do want to go through I'm trying to group the questions into a type of summary. Chetty asks, do you advise going through the apex with a size 08 file? Literature says it's important to clean the apical foramen.
For most cases, I would probably do. That's what I've been advocating. That's what I've been doing. But that is when you're just using so when you work with a file and you're working with something that doesn't measure the whole time, you have to make sure that you haven't plugged the canal, because it doesn't give you a feedback or a reading. So I have to go back with my apex locator to make sure that the canal is clean, and obviously to bring debris into suspension. But because I use it on a rotary file, it gives me constantly, while I work, it gives me a reading. So I'm constantly aware of what my file is doing. Am I blocking it out? Am I not? Because if I don't get a reading, I have done something wrong. I have to stop, revert back to a hand file, go and measure it. But if I see application and what it is, eight file, by just minutely going through the apical portion and back doesn't do harm. It's a great way of doing it. But I've also shown that there's hundreds of portals of exit. So just make sure that you attach it. If you're not using something that measures, that's the method I would do. And it's probably the most predictable way to make sure every time that you're open. But if I am close to a nerve, I stay away from it, because there might be an apical plug, and that might help you that you don't get sodium or anything through the apical portion. What I would maybe then do is at the end, once I've rinsed with my sodium and everything, and there's EDTA in the canal, or smear off, that's what I like to do. I will then go and just make sure that every one of those canals are open, and then go and place my sealer. Then I know I will get a tiny puff through and not a lot of it. If I do it the whole time, maybe I just want to see that my 8 file is on my working length. That's just a safe method of doing it, not over instrumenting it. But no harm. 8 file can't do any harm.
Okay. And I think you know this
gives you guidelines.
I think you know this person. Giovanni Bona asks, what do you think of hypochlorous acid as an adjunct to sodium hypochlorite for irrigation?
Hypochlorous acid, I'm going to just give myself, I know that citric acid, I must help me with a product. I'm not familiar with hypochloric acid. I know there's tricalcium, where if there's resorption, that they can place it in the canal as trichloroacetic acid. I don't know if that's what it, but I mean, sodium has been showed and tried and tested, heated. So I'm not familiar with the exact product, but I'll find you, Giovanni, and we can chat this. Then I can help you. But I'm sorry, I don't know what you're speaking.
What percentage of your cases do you seal with matched paper? Cold,
sorry, can I just go one thing just before? I've read an article, it's actually on their website, which was quite interesting for me, on bioceramic sealers, that they say that they get a better bond and a better performance when they use EDTA as the last irrigation method before they place the bioceramic sealer. And I've been doing it unaware of that for a long time. I use smear off, which is a combination of chlorhexidine and obviously EDTA. But what is the method of working of EDTA and glide and all these things? It's a chelating agent, so it pulls out calcium, and I think it might be due to the calcium that gets pulled out, and it activates and reacts with the bioceramic sealer, and then it forms hydroxyapatite. So that for me, so even if I use sodium or something else, the last bit I would probably just rinse it out with EDTA and then dry it.
It's going to go through. How do you bond to the restoration you initially placed to close the mesial or distal wall before you started the endo on completion of your endo? How do you bond the restoration to you initially placed? How do you bond the restoration you initially placed to close the mesial or distal wall before you started the endo?
I'm going to answer that. I'm not full of this. I always want 4 walls. So the first thing I do is I never have cavite or calcinal. I would build up my mesial wall or distal wall before I start with endodontic procedure, because then I know I can have control and put rubber dam on. So when I'm done with my endo, and I hope somewhere I answer the question, is I would try and roughen it. If it's been for a month or 2, they say within 3 weeks, composite will bond on composite. You would just roughen the composite, maybe air abrade it, which can help. And then a bond like Tokiyama Pelvic Universal, we have an A and a B that you mix the primer bond. It has shown to bond better towards different structures, and that's something that can activate and can bond maybe better to the composite. But yeah, don't do anything special except for sandblasting, cleaning the canals, and etching it, and then go through the normal protocol with it.
Okay. The anonymous last, I think one of Ferreira asked, Dr. Dippenaar, do you see any benefit adding laser technologies into your protocol?
You know, what's a laser? Why don't you just use your light above? No, for sure. Just joking. Definitely that's a lecture on its own, just on irrigation and irrigation protocols. For sure, you obviously have the diode and the water layers. I have a diode myself, which I employ. I would love to have a water lace with radial firing tips, cleaning. It's all about cleaning. In the end, a file is not the answer and the success where it ends and stops. A file is a method to create a space in which we can irrigate and obturate in. So a laser is an amazing method, but some people get too dependent on it and they don't prep properly. And I think, oh, okay, there's calcifications, the laser will blow it away because they don't sit and take hand files and C+ files and negotiate it properly to length, because my laser will shine and will clean it, so I'm not so dependent. If you can't prep properly, how are you going to get the laser tip to length? So I still think all the rest is relevant, and the laser is within this an excellent, everything is an add-on. We have newer sealers, we have newer methods that I showed you of how we prep, and the laser is a great attribute. And I believe in the technology, but it has its place. For sure, it's probably where it will go. I would love to have a laser so that I don't have to use any chemicals, but I don't think we're there yet, because the best is still, I think, in combination and not just a laser, but probably within a few years, we'll have something that we can use. I've read that they are developing newer GP cones with sealers on it, that you don't actually have a sealer that you put in the canal, but actually just the master cone that you place in the canal. So all those advancements. If you look at America, they have the sonic gentle wave, which is a combination of pulses and this minute preparations that they do, cleaning the canals and then go and seal it. So yes, there's a big following on that. One of the guys that I really rate high is Steve Buchanan. And he's also probably one that pushed me into bioceramics, because I've been following him. He's advocated, he has his own pluggers, and he's been doing continuous wave for a long time. And he started changing to bioceramics and the method that he shows. So go and Google the video, Steve Buchanan, and then what he speaks about bioceramics, he changed my mind. But yeah, lasers, great for now and for the future, for sure.
I think, Doctor, that is all. I think we've answered most all of the questions. Thank you very much for a very informative presentation. I've gained a lot of, I think most of us gained a lot of information, not a new knowledge about endodontics. And I want to thank you once again for taking the time out to come and talk to us today. Thank you very, very much.
Thanks. It's a great pleasure. And thanks specifically for SADA, but more specifically for the Free State branch, and for inviting me back to home roots. It's always nice and nice to the people. I didn't see any one of you. I'm sorry if it's hiccups with the videos here and there. You know, if you've been to a lecture, I always like sound and explosives. And unfortunately, you know, it's not possible with this new way of doing it. So I hope I could teach you something, and that you thank you for SADA, and for Marlies. Thank you, and Kurt, nice to see you again.
Thanks, Heinrich. Just want to remind the participants, when you log off, just answer the